Good morning, everyone. Today I will show a patient with high myopia, posterior staphyloma, betapapillary atrophy, and peripheral retinoschisis. The patient was operated on November 2019 for retinal detachment in another hospital and treated with vitrectomy and oil that was removed 6 months later in May 2020. Few months later, has been sent to our hospital for secondary full-thickness myopic macular hole, 700 microns in diameter. So we stain the ILM with the double lutein blue. The difference in this technique is that the ILM flap is folded on the bubble of viscoelastic. The material is injected on the hole. As you can see here, I did the flap first. And then now I'm injecting the viscoelastic on the top of the macular hole. The infusion is closed. So the maneuver can be easily managed under BSS. We don't need air to keep the flap stable. And we know that with air is difficult to manage, and we don't need the PFCL that can be toxic. So the adhesion between the inverted ILM flap and viscoelastic allows the flap to remain in place during the fluid-air exchange and also in the post-op period. As you can see here, now the flap is folded on the viscoelastic and stays there. We always think that the viscoelastic in place there can avoid the closure of the hole, but as you can see then in the post-op 1 week after, I will show you the OCT that clearly showed that the full thickness macular hole is completely closed. So this bridge over the viscoelastic induces the formation of a glial bridge between the edges of the hole above the small viscoelastic bubble. I'm doing now the fluid-air exchange. Just spreading the BSS on the disc, and the flap stays there. I will show you then that is still in place. Okay. And I'm just removing the trigger, and I was tamponated under SF6, and this is 1 week after the surgery. Thank you.